For too long, Australian law didn't just fail survivors, it forced them into silence. Nina Fennell is a Walkley Award-winning journalist and a survivor who helped overturn damaging gag laws in the Australian justice system. She was the driving force behind the campaign that allowed women to finally speak their own names. Her work doesn't just tell stories, it drives change. Hi, I'm Gemma Barth, host of True Crime Conversations. And this very special two-part episode isn't just about the justice system. It's about what happens when women are finally heard. A raw, honest look at the power of a single voice, how silence is shaped, and how women push through it. Hear my conversation with Nina Fennell on True Crime Conversations. Search True Crime Conversations wherever you get your podcasts, or click the link in the show notes to hear Nina's story now.
Welcome to The Kick, your expert-led podcast helping you explore and learn everything about getting pregnant, pregnancy, birth and becoming a parent.
On the podcast and our online pregnancy program, Grow My Baby, we share my experience of helping more than 4,000 babies to be born.
And our experience of running a women's health clinic and parenting 4 boys.
We're here to help everyone to feel empowered in pregnancy and birth with real-life practical information.
Welcome everyone, I'm Brigid Maloney, and today we're going right back to one of our very first episodes, what to do after you get those 2 lines on a pea and a stick. Often it's quite a daunting time. You think, gosh, what do I do next? And what we've done is we've broken it up into can you actually trust the pea on the stick tests? Are they accurate? Or do you need to go and see a GP? And then when you go and see your GP, what information should you take to that visit? And so what we've done since the very start is we've developed a downloadable checklist that is free, and you can get that from our website. And it's a Just Pregnant checklist, and our website is growmybaby.com.au. So hopefully you've picked up this episode because you're either wanting 2 lines on the pea on a stick, or you've just found one. So if you've just found one, congratulations. Listen on, and hopefully you'll get lots of good tips from this episode. All right, well, let's go back, 8 months to when you first find out you're pregnant. Now, we all have a love-hate relationship with these pea on the stick things. Every woman at some stage in her life when she's trying to start a family has got the box of pea on the sticks.
Yeah.
Anyway, so we've done our we've got 2 lines, and by the way, it gets asked of us a lot, doesn't it? Even if there's a faint second line on a pea on a stick, you're pregnant. Yeah,
read the box to make sure what a positive test is supposed to look like. But on the 2-line ones, even a faint second line is pregnant.
Yeah,
the tests are extremely accurate and very, very, very sensitive. So they'll pick up levels of beta-HCG, which is the pregnancy hormone, when the level reaches about 5. And in early pregnancy, the level might be 50,000.
Yeah, wow.
So they'll turn positive as soon as that pregnancy hormone is present in the urine, which is as early as a couple of days before the missed period.
Wow. So I can actually start testing just days after conception? No.
Yeah, well, a few days before so if ovulation happens in the middle of the cycle, and then a little time takes for sperm to meet egg, and then a little time for them to get together and come down into the uterus and implant into the wall of the uterus. But there's some beta-HCG pregnancy hormone present even before the missed period. So even before you're pregnant because you're overdue.
Yeah, wow.
Yeah.
All right, so we talked a little bit last podcast about, just any generic pregnancy test. So any cheap pregnancy test will pick that up.
Yeah, they're pretty simple. And, there's some fancy ones that try and tell you how many weeks you might be pregnant and so forth. But let's say that's a couple who are trying for a pregnancy and they're monitoring their dates and they know precisely when to look. Okay, as soon as the period's due on one day and it's not there, then that couple will look. And all you need is a yes-no test.
Yeah.
And it doesn't have to be fancy or expensive.
Yeah. Well, how exciting. It is. Mostly it's exciting. I know that sometimes a positive pregnancy test isn't looked or hoped for, but mostly it's exciting.
Yeah.
So you've got your positive pregnancy test. How long do you wait before you see your GP?
Well, I think that one of the we'll return to this again and again, but one of the great ideas is to have already been to see your local doctor before you get that positive pee on a stick test, so that a lot of the things are already sorted out. And by that I mean that you've had a chat to the GP about being on some folate supplementation, that your protection against rubella has been checked or boosted if it was thought to be inadequate, and perhaps even had a conversation with the doc about care models, so that you know a lot about what to do when you already get that positive test. But let's say it was a bit of a surprise, and that pre-pregnancy visit hasn't happened. So the things that are important at that stage, once you get that positive P test, is that you're on some pregnancy multivitamin or at least some folate supplementation. And that's when we make a visit to go and see our GP, and hopefully getting to see them at about the 6-week mark.
Okay. And what is the 6-week mark? Is that from the first day of your last period?
Yes, excellent. So okay. That's a really important question. So let's make sure we're all on the same page about that. When we talk about 6 weeks pregnant, we mean 6 weeks from the last period. Not 6 weeks since the ovulation, or 6 weeks since intercourse, or 6 weeks since we got the positive pregnancy test. We mean 6 weeks from the last period.
Yeah.
And this is an old-fashioned idea, but it dates back to the days when there were no ultrasounds and there was no great understanding of the hormonal basis of ovulation and so forth, so that all we knew were the dates.
Yeah.
And a woman was said to be 10 weeks pregnant if there had been 10 weeks since her period, because that's all we could know for sure.
Yeah, that's right.
Yeah.
So you go to your local doc, and we know from our experience in our practice that there are many, many women who actually don't have a local doctor.
Yeah. Yep.
You know, they've been for years they've either moved around and they haven't sort of picked up on a GP that they go to regularly. And let's face it, so many women are just healthy, and all you need to pop to the doctor for in those days is, you know, maybe the treatment of the odd UTI or something, and you head down to your bulk billing 24-hour clinic. Yep. And you haven't really built that rapport or that relationship with the doctor.
Absolutely, and I think that's a pretty common scenario these days. So you really only need to see the local doc at that 6-week mark to have a talk about those big ticket things and folate and so forth. Get some pregnancy blood tests organised, the first round of blood tests, and ideally arrange for an early scan. And that can be done through any local doctor. It's really nice if you've got an established local doctor who you can go and see, because building up a relationship with that person is a terrific thing to do, not only during the pregnancy, whether you're having your care as shared care with that doctor, or shared care with a midwife, or shared care with a consultant obstetrician. The GP wants to see you in pregnancy and help to look after you. And then when you've got a newborn, you're never at the doc more than that.
Yeah, that's right. It seems like every sniffle you're down there, because you really, you know, it's such unknown territory.
Yeah, you're nervous.
Yeah,
It's a rash, a runny nose. You're at the doc a bit, and a lot of people get their vaccinations for the baby through the local doc as well. So if you're a client of an established clinic, even if it's not the same doc every time, it's at least the same practice.
Yeah. That's
a really nice thing to be thinking about at this early stage.
All right, so you've got an appointment with your local doctor at 6 weeks. What do you have to tell them?
Well, what they'll want to know at that stage is just back to basics. Is your history, is this your first pregnancy? Are you pleased to be pregnant? Before I was a specialist obstetrician, I was a GP for a little while many years ago, and that was the phrase that I'd worked out was a tactful way of opening the discussion. And if someone's not pleased to be pregnant, then it's a whole different discussion.
Yeah, that's exactly right.
So if we open with, are you pleased to be pregnant, then, and the person says, yes, of course, we've been trying to get pregnant for 3 or 4 months and tracking our ovulation, and we're thrilled. Then there'll be some early questions about the woman's medical history, and also histories for the partner, family history, whether there's anybody in the extended family who are any unhealthy or unusual babies, whether the woman or her partner have any issues with drugs and alcohol. I think these days it's very important that we get in early and ask people about things like family violence. Family violence is a problem that gets worse in pregnancy.
And then that might be kind of quite confronting for someone that's just come in with really happy news that they're pregnant.
Yeah.
Why do you actually ask them?
Well, we don't have to go. You don't have to ask that up front.
Right. Good.
Okay. So what I say to my students is, don't forget to say congratulations.
Yeah. Oh my God.
And be happy. Be happy for the patient. But at some point, we do need to ask about those serious things, those negative things. That's part of pregnancy care.
Right. I would imagine too. Another thing that you'd be asking about is their mental health.
Absolutely. So people with let's use that as a great example. A woman with a history of depression and anxiety, for example, which is common, she might be on a medication at that time, which is okay for her to be on in the first few weeks of pregnancy, but may not be an ideal thing to be on for the whole pregnancy. So we like to see her at the start so we can say, fine, let's change her from drug X to drug Y that's got a better pregnancy safety profile. We also know that pregnancy can be a challenging time for people for anybody, but also for a woman with a history of depression and anxiety. So we would say, how are you coping? Are you pleased? Is your family pleased?
Have you got any sort of support mechanisms?
Absolutely. And then let's say the woman, she's been fine. She's been totally fine mental health for a couple of years, but before that she'd had some issues. Well, this might be the perfect time to reconnect with her psychologist, go back over the principles of the cognitive behaviour therapy, happy thoughts lead to happiness, not to go down negative thought spirals. And because the pregnancy itself, it's a funny time hormonally, it's a time of great change and flux, and it's a time when mental health problems can be
out. Really triggered, I could imagine. It is. You question everything and you're so anxious about, right now, but also the future. Like there's a lot coming onto your plate, isn't it? It's not just that you're growing a baby. It's like, your lifestyle's going to change, your relationship with your partner may or may not change, and all of those things seem to sort of just come in on a person.
Yeah, and those aren't things that are going to change for someone with a history of a mental health problem. It's going to change for everybody.
Everybody, that's right, yeah. All right, what other sort of medical history is your GP interested in?
Any health problems you've had in the past, be they medical or surgical, asthma, epilepsy, diabetes, thyroid, history of operations, I had tonsils, gallbladder.
Really? What would tonsils and gallbladder have to do with?
Well, let's say, for example, I had the person has a history. I had my gallbladder out, and I had a severe anaesthetic complication.
Oh, yeah.
We want to know that.
Yeah.
We want to know what that was, and how did you go? And let's say, cut forward 8.5 months, you have a caesarean section.
Yeah.
We want to know what the anaesthetic problem was. So everything's relevant. It might not seem so, but everything we're going to ask at that early stage is relevant.
Yeah.
And there'll be a method in that madness. So absolutely, medical and surgical history, mental health history, lifestyle issues, drugs, alcohol, and it's all part about building a picture, which even as early as that first visit, what's going on in your caregiver's mind is stratifying the risk. Is this a person with a complex medical history where the pregnancy is going to make a difference to the medical problems they've already got, plus the medical problem is going to make a difference to the pregnancy? And that's a complex person, and we might say to that person, whoa, this is all looking a bit tricky. Perhaps we'll get you off to consultation with an obstetrician straight away.
Yeah. Because
you've got a lot going on. Versus somebody who's totally fine, regular cycles, history of perfectly good health, normal childhood vaccinations, who's got no issues at all. And you might say to that person, congratulations, fantastic, let's organise a dating scan, and you can go and book in at the public antenatal clinic in whenever they'll see you.
Yep.
And if that's not till 15 weeks, doesn't matter.
Okay, yep.
So we're trying to work out the appropriate place to send people and the appropriate time frame to send them there.
So when, you often think that you have to go to the doctor because you need a blood test to confirm the pregnancy. Is that the case?
Yeah, you don't need a blood test to confirm a pregnancy. So the urine test is extremely accurate, and if it says you're pregnant, you're pregnant. It doesn't say that you're not going to miscarry. or even that it's not an ectopic pregnancy that's stuck in the tube rather than in the uterus, but it does say you're pregnant. So the blood tests are not just to confirm that a healthy person with a normal pregnancy is pregnant. We already know that from the positive urine test, and an ultrasound at 6 weeks will show us that the pregnancy is in the uterus and the heart's beating. So that person certainly doesn't need a blood test that counts up the amount of pregnancy hormone. That's called a quantitative beta-HCG, and that gives you a number, like the number might be 1,000 or 20,000. Those blood tests are for where the situation is not clear. So, for example, we do an ultrasound at 6 weeks and the woman's pregnant but the uterus is empty. And we think, okay, what are possibilities? Might be an ectopic pregnancy, might be somewhere else. It might be an early miscarriage, or it might be that we're earlier than we think and it just hasn't had a chance to show up in the uterus yet. Well, if we get a pregnancy hormone level, that will help us answer that question.
Yeah, right. So that's that beta-HCG.
Yeah.
Yeah.
And we might do 2 of those in a row, and if we do one on a Wednesday and it's 1,000, and we do one on a Friday and it's 2,000, then that's doubling normally every 48 hours, and that's a sign of healthy. If it was falling over that 48 hours, probably a miscarriage.
Yeah.
Staying about the same over that 48 hours might be ectopic. So that's what those numbers are for. But they're not really to confirm a normal pregnancy.
Yeah.
And they're not very useful to confirm a normal pregnancy, because if you're 10 weeks pregnant, the normal range of quantitative beta-HCG might be 5,000 and might be 20,000.
And it's different for every woman too, isn't it? So there's no point in comparing yourself to anybody else.
No, and it doesn't predict outcomes like that.
Right. HCG. What does it stand for? What's that acronym?
B is for beta. That's just like the Greek alphabet. There's an alpha HCG and a beta HCG. And H is human. C is chorionic. And chorionic means is part of the early pregnancy. The chorion is the outer sac. And the G is something called gonadotrophin, and that's just what the hormone's called. Right.
Okay, good. Because people do talk a lot about HCG, and they sort of tend to, well, they're at that point where they're anxious about a miscarriage and they start talking about HCG and, you know, the levels of HCG. But the big thing that I'm getting from you right now is that it's just as if it's doubling, and don't compare yourself to somebody else's HCG level.
Absolutely. So in 2019, the management of what's called the unsighted pregnancy, so we know the woman's pregnant, but we're not sure whether it's in the uterus where it belongs, miscarrying, or ectopic. The management of that is based on ultrasounds and interpretation of serial beta-HCGs, so having a few in a row.
Yeah. And
that's how the diagnosis is made. But if we're in this territory, we're under an expert help.
Yeah, a medical expert, and we should just sort of know that they've got that.
Yeah.
Yep.
I'm Kate Langbrook and I host No Filter. Celeste Barber.
Hi.
Welcome to No Filter.
It's nice to be here.
Yeah, today we're diving into the world of G-Flip.
And your voice has always been such a calming, warm energy. So that's why I tear up, because you're like always growing up with you around. So thank you.
Sally Hepworth, what an absolute jewel you are in the crown of artists.
Oh, thank you. This has been lovely.
Today, we're talking to Rosie O'Donnell.
I just want to tell you, this is one of the best interviews I've ever had.
If you love conversations that go deep and stories that stay with you, listen to No Filter. New episodes of No Filter drop every Monday, wherever you get your podcasts.
All right, so does every woman need or have a dating scan?
It's a good question. You don't absolutely need a dating scan. If you're pregnant and there's no sign that anything's wrong, like you've got consistent pregnancy symptoms, there's no early pregnancy bleeding, then it is safe to assume that things are fine. And we probably tend to get a dating scan done. The dating scan probably doesn't tend to get done until it's done, for example, as part of Down syndrome screening, which, depending on what we're doing, might be 10 or 12 weeks. And that might be the woman's first scan, and that's fine. But if she wants a dating scan, or if one's thought to be necessary because there's some confusion about exactly what's going on, then from about 6.5 weeks you can see the what's called the fetal pole, which is the start of the baby, and the heart beating.
Oh, you can actually see the heart beating.
Yeah. So the baby looks like a tiny little jelly bean, and in the middle there's a beating heart.
Yeah. Oh, how cool.
And the whole thing's only a few millimetres long, but you can quite clearly see that going on.
And you have to go to an ultrasound clinic for that.
Yep. So the GP will send you off to an ultrasound clinic. A lot of obstetrician and gynecologists like myself have got an ultrasound machine ourselves, and I might see people in very early pregnancy if they're worried and scan them myself.
Yeah. And do you know whether that is bulk billed or whether you can have a bulk billed early dating scan?
Yeah, so there are some ultrasound clinics that offer bulk billing, and an early scan is not rocket science for them to do. So when your GP sends you for a scan, like anything else, you ring up to make the appointment and you ask very clearly how much it costs, and don't hesitate to shop around a little bit.
Yeah. Yeah, that's right, because there are lots of providers out there, isn't there?
Certainly.
Yeah.
In the ultrasound world, there's big variation between, for example, the ultrasound department of a public hospital, which is free to go to. It has it might not have as many appointments for people because it's a busy public hospital clinic that's looking after the patients of that hospital, the inpatients of that hospital, but it's available for people to use as an ultrasound clinic. It's usually free. It might not have as many bells and whistles as a private clinic, but that's fine. Right up to the full-service private clinic at the end of your street that will charge you an out-of-pocket cost, but they'll give you photos and a video and a DVD and a USB with the pictures and everything.
So, Pat, how do we even know, when our babies are due? How do we have a date in mind for that?
Yeah, so good question. This is about something called an EDD or an EDC. And an EDD is estimated date of delivery, so basically when the baby's due. And an EDC is a beautiful old-fashioned term. That's an estimated date of confinement.
Oh, confinement. Gosh, I haven't heard that for years.
So some of my senior colleagues in obstetrics still say confinement. So that's back in the day when the pregnancy was shrouded in mystery.
And you had to hide at home and never let your belly be shown.
Yeah, so the woman would be confined to her house for presumably weeks before delivery, and it's a hangover from those days. So basically the due date, there's two important ways to calculate that. One is based on the period dates, and that's extremely accurate if the woman had a nice regular cycle leading up to conceiving. And it's very reliable that the baby's due 40 weeks after the woman's last period. Again, not the date of sex and not the date of ovulation, but the date of the period. In the pre-ultrasound era, that's all they knew. So you can just calculate, and you've seen your local doctor's got one of those wheels where you turn the wheel around to the known date of the first day of the last period, and then the arrow on the other side will indicate the date that the baby's due.
Yeah.
It's important to have an answer because a lot of the tests during pregnancy are timed, so we need to know when someone is 28 weeks and when they are 36 weeks. But it's particularly important at the other end if we're going to interfere in the pregnancy because we think the woman's overdue, then we need to know she really is.
Mm.
The other way to calculate the estimated due date is off a dating scan. And first trimester dating scanning done transvaginally is very accurate.
Okay, hang on a minute. What is transvaginally?
Well, that's that glamorous procedure where the ultrasound is done internally. So that you.
Oh, yes. I've had quite a few of those. That's the probe.
Yeah, so the probe with the cover over it that goes up the vagina, and it puts the source of the ultrasound beam, which is the wand, right up close to the pregnancy, and the pictures are much better.
Right.
And if you've got a good view in early pregnancy, then everybody's 6-week fetus is the same length. Genetic differences haven't come into it yet. So if you're an African or an Eskimo, it doesn't matter. It's going to be about the same length. And so we can say very confidently that if the early pregnancy is so many millimetres long, then it must be so many days and weeks old.
And how often is that different from somebody's estimated sort of last day of their period and what they think how pregnant they think they are?
Yeah, it can be. So if you've got an irregular cycle, you can be more or less pregnant than you think you are. If you had an episode of bleeding in early pregnancy that happened about 4 weeks in and you thought that was a period, but it was in fact a bleed at 4 weeks, then you're 4 weeks more pregnant than you thought you were.
Yeah.
And if there's a significant discrepancy, the period dates are more likely to be wrong than the ultrasound.
This is a little off topic, a little down the way, but it's of interest. So it's always puzzled me why women might get to that point and they find out suddenly that they're 20 weeks pregnant. Like, how does that suddenly happen? I knew the minute I've been pregnant all 4 times.
Well, it happens. I mean, some people just don't know. So you could have no pregnancy symptoms at all. You might be somebody who only menstruates twice a year anyway, so you don't notice the absent period. Some women continue to bleed a little bit, even in a regular basis in the pregnancy, and think that they're just having periods. So it happens.
Okay, sorry, that was off topic. Anyway, back to it. All right, so we've covered taking of the medical history, a dating scan. What are the other bloods for? What do you need a blood test for?
Well, the blood tests in early pregnancy are mostly an infectious diseases screen.
Oh, yeah.
So historically, some of the major problems in pregnancy were related to infectious diseases. And we don't see tons of those these days because of vaccination and because of improved living standards and nutrition, but we still check for those things because some of them can have a devastating impact on pregnancy.
So what are we talking there?
Well, we still check for syphilis.
Syphilis.
Yeah, I've never seen a positive syphilis test in pregnancy in all of the time I've been doing obstetrics, but it's still checked for because there is a little bit of syphilis around in our country, and certainly globally it's still around. And a syphilis infection in pregnancy is catastrophic. Causes dreadfully severe fetal abnormalities. So that's still checked for in 2019. Probably of more relevance, there's a check for hepatitis. That's because we now know the way to reduce what's called vertical transmission. So if the mother's got hepatitis B, C or HIV, we can stop that being passed down to the fetus in pregnancy.
Wow.
And so we can't do that unless we know who's got it. So that's what those tests are for. There's a urine test as part of the first lot, which is about finding women who've got what's called subclinical UTIs. So they've got bacteria in the urine, but they feel fine. And we know that those women, if that's not picked up, may carry that bacterial infection through pregnancy, and that can be involved in things like premature labour and delivery. So that's what the urine culture's for. And then we look for the blood group. It's very, very important. Women who are a negative blood group have some special potential complications of pregnancy, which we'll cover in a future episode of The Kick. And so we want to know what the woman's blood group is and whether she's got any abnormal blood antibodies. And then lastly, the hemoglobin, just hemoglobin and iron levels to make sure that they're adequate for a nice, healthy early pregnancy.
Yeah, great.
Hello, Holly Wainwright here. I'm an executive editor at Mamma Mia, and I have been part of this business, an independent women's media company, for more than a decade now. I have seen a lot, but being independent has always meant that we don't have anyone telling us to play it safe or to avoid the topics that feel a bit too messy or uncomfortable for a boardroom full of dudes to handle. And I never take that for granted. If we help you feel a little bit less alone or more connected through the conversations with fascinating women that Kate Langbrook's having on No Filter or one of our other shows, or if we help you feel more informed with the stories that your group chat is really reading on the Mamma Mia app, please consider, please, becoming a subscriber. Because your support really helps us keep telling the stories that matter to Australian women. As a Mamma Mia subscriber, you get unlimited access to everything. Every article, every video, and every single podcast we make. You can even move with me. Subscribers get full access to our at-home fitness app, including my new weights program, launching soon, I promise, with an expert and not just me. Subscribe to Mamma Mia today. Support independent women's media. There's a link to do that in our show notes.
All right. So is there any other things that would happen at your first GP visit?
Well, I think the other thing that would commonly happen is the GP would ask you, rightio, well, where do you want to have your care?
Yeah.
And we're lucky in Australia. We've got options.
So many options. It's so many options that sometimes it's a little confusing.
Yep. It certainly can be confusing, but I think we can help people, sort of clear some of that confusion a little bit. And that first visit with the local doc is a great idea to get the local doc's view on that and the options that are available to you in your local area. The pregnancy care in Australia is typically provided by a number of different practitioners, from midwives, from GPs, from independent midwives out of a hospital up to consultant obstetrician. And there's a choice available to people, which is terrific. So the GP can help you find your way through that maze. It's good idea in the first trimester to make a decision about where that care will happen. The antenatal clinic of your local public hospital. You might go there at 10 or 12 weeks and be assessed again as to whether you've got high-risk issues that need to see the doctors and obstetricians every time, or whether you've got lower risk issues and can go through the midwifery clinic, see a midwife each time, and be booted out back to the high-risk clinic if you develop some abnormality. Or you might be able to see a midwife practicing outside the hospital who does lower-risk obstetric care in the same way. And then a lot of people can have care through private obstetrician, which is what I do for a living. It's a very, very rewarding relationship, I think, where people get to see the same person, i.e. the obstetrician, right through the pregnancy for each of the visits, and also have that person attend the birth to support the woman in birth and deal with any complications that could arise.
Yeah.
And then lastly, there's a thing called shared care, where you can have your pregnancy visits with your GP, if they're a GP with an interest in pregnancy care, and then from time to time a visit at the hospital.
Yep. And it really, your decision might be based around whether you have private health insurance or not. Mm-hmm. And we do see it in the practice where people want to come and see you, but perhaps they haven't had their private health insurance for long enough. So, it's another thing to put into your pre-planning stage and phase.
I think it's on our list, isn't it?
Yeah.
Yeah, that if you're thinking of having a baby and you're thinking that when you are pregnant you might go through a private obstetrician, and in particular to give birth in a private hospital, then you need to have your ducks in a row with insurance in advance.
Yeah, at least 9 months in advance.
Yeah, well, most of the health funds, if you increase your cover to cover pregnancy, then they won't cover you for a year.
Yeah.
Now, the year includes the 9 months of the pregnancy, so then once you've increased your cover, probably not, if avoidable, not to get pregnant in that first 3 months. Then by the time the pregnancy's run its course, your year will be up.
You should be fine.
Yeah, because the bit the fund are paying for is the delivery and the private hospital stay at the end.
Yes, yeah.
So the 9 months of the pregnancy are going to count in that year.
Mm. So let's say you don't have private health insurance and you go to your public hospital and you're in the antenatal clinic. You mentioned that they may not see you if you're considered low risk until about 15 weeks. So is this something that your doctor will discuss with you? What happens between their visit at 6 weeks and when you see someone at the antenatal clinic?
Yeah, that's a terrific question and something that I'm quite passionate about, because in that gap there's a couple of things that need to be done, and the big ticket one is Down syndrome screening. So if the couple want Down syndrome screening, that needs to be organised through the local doc, because the window to get that done is going to have expired by the time the couple get to the public antenatal clinic, if that's where they're going. If they're going to a private obstetrician, I see patients who are referred to me at 10 weeks so that I can organise the Down syndrome screening, because I've got my people who do it well and so forth. But a patient on their way to the public clinic, that's going to have to be sorted out first.
Yeah.
Yeah.
And look, we'll do a whole other kick episode about Down syndrome screening and the NIPS test. But I think, it's just important for women to talk to their GP at their 6-week visit about what their plan might be for their Down syndrome screening. Whether they have it or not, that's choice.
Oh, yeah, that one's optional. You don't have to have it. But if you do want it, it's very important and dear to my heart that it's offered to you at the right time.
Yeah.
So that we don't have people turning up in more advanced pregnancy who haven't been screened.
And this is all about having the knowledge to be pre-armed with the facts. We have seen it before, haven't we, where somebody's come to our practice and they've come later, they might have, swapped out of the antenatal care into private care or whatever it might be, and that window has passed. So, that's a point of great sort of confusion and frustration.
Yes, this is our part of our knowledge is power mantra.
Yeah.
We really want to see an educated group of young women who know the basic facts about these things, so that they can take personal power and responsibility for making sure that some of this stuff gets done properly.
Yeah.
And that they can take full advantage of all of the technology that's available. And I guess our ideal patient out there, our ideal young pregnant woman is someone who is literate, pregnancy literate, knows about these things and says, okay, I already know what I need and I'm interested in the doctor's expertise, but I've also learned a lot myself.
All right, so what are we doing? Is everything at the GP's, that's a lot to cover in a 20-minute appointment.
Well, that's a good point. You should book a long appointment. It's an awfully long time ago, but I was a GP once upon a time, and book a long appointment, especially if there's something to discuss.
So you're ringing up the receptionist and you're saying, I need a long appointment.
Yeah. And I'm sure the GP would love you to book that in advance, especially if there's a lot to discuss.
Yeah.
If you think it's going to be, the GP goes, congratulations, here's some blood tests, here's an ultrasound, and here's a referral to Dr. Maloney, then great. 10 minutes is done.
Yeah.
But, if this is your first pregnancy after a period of infertility and you've got a history of type 1 diabetes and hyperthyroidism and a strong family history of cystic fibrosis, then, okay, there's a bit to do.
Yeah, that's right. Thank you, everyone, for listening to our episode. I hope you are now the full bottle on what to do next now that you've got your pee on the stick. As we always say, if you find our information useful, then share it with a friend. And if you are so inclined, please give us a 5-star review on either Spotify or Apple Podcasts, because that then helps those platforms to push them out to other people. And that really helps our message get out to all those people that are probably floundering with some information on pregnancy that they need. All right, until next week, we'll be back in your ears then. Keep growing those babies. Bye for now. Hey, even though Dr. Pat is, a doctor, and we get lots of other doctors and other experts on our podcast, I just need to remind you that this podcast is for informational purposes only. We share lots of medical insights and experience, but everything we talk about is general in nature and may not apply to your specific situation. Please always consult with your own healthcare provider for your individual medical advice when you grow your baby.